Hello, hello, hello. How are y'all doing? How are you doing, Dr. Storch? How you doing?
I'm living the dream. Glad to be here with you today.
Well, I know this is the dream, right? Like when you when you first entered this field, you're like, I hope there's this guy out there suffering with OCD, gets better, becomes a therapist, and hosts live streams so I can be on it because that's the top echelon of the work you've done.
Hey, you nailed it, man. And I enjoy our pre-conversations about pizza and the quality of pizza in various states. Uh,
Yes. No, I'm telling you, California great. We live a whole like 2 years longer than everybody. And it's because I had pizza last night in LA. It was cauliflower crust. It was really thin. They used a like non-GMO, gluten-free, no sugar added sauce. And the cheese was like vegan cheese. And I looked at cardboard floating outside and thought that might have a little bit more taste than the pizza I'm eating. So that's our state of pizza out here in California.
that sounds awful. I'm available after this to talk about that and provide some sort of support, but I'm sorry.
Well, I don't know if you know this. I actually already called your center and asked for an appointment just for this. So,
100%
well,
necessary.
but that's the good news, right? Like when you get in like non-clinical OCD, you get to complain about traffic and pizza instead of like, hey, did I just kill someone this morning? So it's a great balance. I'll take that any day.
Any day.
But I'm super excited to have you on. You're kind of, I think, the last person of the year. Hold on, let me see this. Let me not make such a bold statement. Oh yeah, because next Wednesday's Christmas. So you are the last guest of the year. When we were deciding who did we want to round out the year, it
Uh-huh.
was you. So I'm excited to have you.
Yeah. Well, hey, hopefully we can bring it home strong.
Yes, well, I'm really excited because I know usually we have a topic and we were all talking about what topic. And then when we had our meeting this week, I was like, we don't need a topic. I really would just like to ask Dr. Storch some like general OCD questions. We have a lot of people that are going to be asking questions because I think, people are struggling. They want to know what to do, where to go. And you've done so much and led so much of the research and the training and, everything that you do. So just excited to have you on. Do you want to do like your elevator pitch of who you are? I'll give you the reins. I'll add some like flattery stuff after, but
Oh man. Well, four-year letter winner, varsity soccer, Binghamton University. Uh, I but that's sort of my claim to fame. Above average dancer, and then that didn't work out, and so went into OCD, where I'm really proud of the work that we've done and the team we have at Baylor College of Medicine, where we have both a clinic and then a research enterprise and an educational focus to try to train the next generation of folks out there, expand access to people that need support, and hopefully do some good science too.
yeah, I mean, me personally, growing up, going up, kind of like throughout my training and things like that. I always remember a lot of the research that you did. I included in my thesis, and so it's just been like an honor to. I just had John Hirschfield on the Family and Loved Ones group my mom and I run. I have you on this live stream. So I think of people like you really leading the charge. And research is so important and all the stuff that your lab puts out because it then informs us as clinicians what we're seeing is working in a study and trial basis. And I know a lot of stuff that's come out has helped. One thing that you said that I always remember is the research found that the sooner you start exposures with kids, like the quicker they get better and they actually handle it really well. And I think if you didn't have that research, a lot of times on the flip side, you would think, oh, it's a kid, let's go slowly, let's go gently. But after that training with you, I started feeling more like bold. I'm like, okay, the training says that. And I've, started to see that like kids are like, let's go. I am tired of like this boogie monster OCD bullying me around. Like, let's go. So thank you for informing clinicians like myself.
Yeah. No, well, first, I mean, yeah, it's a thrill, and I will say too, while you may have been studying some of this as you went about your advanced degree, in my mind, I'm like a solid 24. I'm not old. I look on this screen, and I'm like, where'd my dad come from? Um, but uh, but no, that I agree. I think a, of the importance of research. And I think a lot of it informs practice in a really clinically meaningful way. So you gave that example. And even this morning, I was reminded of this paper that we did where we looked at sudden gains. And your point, Chris, was really good. Like what we found that about 40 plus 45% of kids with OCD have sudden gains in treatment, which means they have this like really quick improvement. And the biggest predictor of sudden gains or that quick improvement was engaging or starting exposure tasks. And so it's all about doing the therapeutic concepts that are most effective, of course, at the right time and the right sort of intensity with values of, sort of guiding our exposures. But it's key to again, do the components of treatment that are really most salient at play.
Yeah, I'm gonna read you this. It was a post from a person with OCD, but I thought this was so cool because it speaks to like what you were just saying about how important it is to see like values driven work. And I think a lot of times when people look at the treatment for OCD, they're thinking like, okay, this sounds really dangerous for my kid. Or, a lot of times people reach out to me and just say, hey, like I've heard your story, but I don't want to jump in dumpsters, or I don't want to like throw knives at people. And I'm always like, I'm like, that's not what we do in treatment. That's what we do on Ultimate Ninja Warrior, but we don't do that in sessions. But I wanted to get your take because I thought this was like the most beautiful post. So they said this is somebody who's recovering from OCD, and they said something I find really beautiful about ERP that I have noticed after I've made progress in it is the exposures eventually end up becoming activities that you dreamed about feeling able to do for years. This merges your values and desires to live life outside of OCD's influence. The therapeutic model eventually becomes a lifestyle that is very empowering. I started in a confined, dark place, and I continue to just living my life. And that's like some of the work that I'm trying to do with Liz, and I know we're all trying to do as a community, is to explain like we're really engaging in treatment. Like, a client with POCD who hasn't been able to visit their nephews in 4 years, the treatment is trying to reconnect them with a family member that they miss. So can you speak to it, like for the people that might look up the treatment and be a little bit intimidated by it? What do you see in the studies, or as well as like clients, like how do they embrace treatment?
Yeah. So I have a whole bunch of thoughts on this, and the first on a sort of a clinical stance is that exposures have to be functionally related and really at their core are values based. Now here's what I mean. It's just, Chris, what you said. Like you're doing things that a person cannot do, but they want to do or they need to do. If it's not relevant or important or anything, you're not going to target that. So the exposures are all very functional in terms of what you're trying to learn, what you're unable to learn if you keep engaging in avoidance or rituals, and then the outcome that you glean from doing it, and collaborative as well. One of the things I love about our lab is we sort of have these like couple groups of studies, and I'll break it down as like stuff that's funded, and then stuff that's like we're just like, yeah, that's interesting, and this can come in all different forms. So one of the studies I love that we did with one of my the time fellows who's now continuing to do incredible work in OCD in Australia, particularly with people who are older, is looking at attrition to ERP. So I remember I'm reading this article, and I read a few more that cited this notion of 25% of people drop out of ERP or can't tolerate it. And I was like, it's not what I'm finding. Like, in fact, I'm finding the exact opposite, that our engagement is longer than average, that we see very little dropout. And whenever there was dropout, there tended to be sort of another reason that would explain it, that wouldn't be specific to ERP. And then I think the other point that's sort of relevant is like certain statements, they need to be placed in context. So a certain proportion of of people will drop out of any intervention. So that said, we want to look at this empirically. And so we did a meta-analysis, so we have averaged all the studies that were out there in kiddie OCD to see what attrition was. And we found that it was about 10%. So 90% people maintained. And Clarissa Ong did this in adults and found it was slightly higher, but about 13, 14%. And then what was interesting is that ERP attrition, and talk about our kiddie study, was lower than any other treatment except for one, which was waitlist. And the reason behind that is because after you waited, you got treatment. So you were hanging in there to get what you wanted, but it was lower statistically than medications, other active therapies, and so on. And so again, it goes to this notion of the right treatment provided in a way that's consistent with what's important to the kiddo or the adult um, and family is really acceptable, but also really effective. There's this other paper that we just wrote a commentary on with my good friend Tara Paris of this Nordlots follow-up. So this cohort of 269 70-ish kids from Scandinavia, and they did this amazing project. Trained kind of average Jane and Joe clinicians to do CBT with ERP. So not specialists. Norway and Sweden and Denmark, and so about 70+% of them got better after 14 sessions, and then after that you either got more CBT or sertraline. About 50% of each of those groups did better. And here's the point: then they followed them in time over 3 years. You know how many were doing great 3 years later? 90%. And right, like that's the thing. 74% remitted, 16% had mild OCD, so still some work to do. About 9% were still struggling. So we got to figure out how to help that 9%. But at the same time, I also want to say, let's be balanced. So let's acknowledge that 9% we got to support, but let's also applaud that this study followed kids 3 years later, and it gives hope to parents. That they know that if they engage in these effective interventions, that 90% of the time their kids are going to be doing pretty well in a few years. And so I really hammer home those data, which can inform practice, optimism, and treatment engagement.
Absolutely. I mean, one thing that you said about treatment dropout, we take a Kaiser insurance where I work for our IOPs, and we have to report the data to Kaiser. And so if somebody drops out, et cetera, but we were looking at the numbers and we didn't have the dropout rate sometimes people talk about. And we had like 8% dropout. And typically, like you said, it was because we found that they were dealing with a co-occurring disorder that needed primary focus. Maybe it was PTSD, maybe it was depression to the point they couldn't even make it to treatment. But I think a lot of times some of the numbers people see and then kind of freak out. Sometimes people will say stats like only 50% of people get better from ERP. And I'm like, I don't know what's happening there, because in sessions that I do, and I don't think I'm special, I don't see that 50%. So it's good to hear. I will say with that study, if you look at my last name, you can clearly say it's Scandinavian because I'm half Norwegian. So it might have just been that good because Norwegians are amazing people, and that might be what it is. But it could have skewed the data a little bit.
Yeah. Well, this is all fair, and I will say, as someone who's challenged on hair, that my biggest concern in Norway is like it's freezing when I'm there. Like I have to wear hats, so it's a little embarrassing. But I've seen that too, that 50% thing. And here's the thing: there's not a single study that has found that for exposure-based therapy. It's really impressive, and there's this concept called variation in care, which can be determined on lots of things. So it could be that you have OCD and you go to hey Liz, you go to Liz and you get first rate exposure-based CBT, or you go to a clinician that doesn't know OCD and you don't get that. That's the variation. But what we see in our research studies with ERP is actually incredible lack of variation in outcomes. So everyone pretty much finds in the same band, and occasionally there's an outlier that's too good. Once in a while there's an outlier that's not as good, and you can usually understand where those outliers sort of come from in different ways. But at the end of the day, what you're really seeing is this remarkable consistency across studies in terms of their effects, whether you're an adult or kid, or you live in the US or Canada or Europe or Australia. And so that part also gives us assurance of the overall effect that we're seeing with our first line interventions. Likewise with antidepressants, very consistent findings across studies in kids and adults relative to pill placebo.
Well said. Hi, Liz. I like how Liz shows up looking better than both of us, and now we just look like munchkins. So thanks a lot, Liz. She has the cute shirt, the hair. We were just talking about just in general. Eric's our final guest of the year, so we're excited to have him. I'm just kind of picking Eric's brain. And to everybody that's just joining us now, there's a lot of questions in the chat. I promise we'll get to them. This is always your live stream, so any questions you have for Dr. Storch, any questions you have in general, we'd love to ask them. Like I said, I'll throw this question out for both of you first. It was from, oh, I'm so bad at time changes. But Emilio is from 4103 Sauderin. They ask, can you talk a little bit about the difference between habituation model in ERP and inhibitory learning in ERP? So
Mhm.
it's like 142 on my end. So I think that's 442 for you, Emilio. But the difference between habituation ERP and inhibitory learning.
Yeah, yeah, and hello to everyone. I just hit the comments and I was like, oh my gosh, that's a lot. Well, thank you for joining in. Yeah, so there are different kind of explanations or mechanisms for why ERP may work, and one of them that has really been around for a while is this kind of habituation model. And so the whole concept there is the more you do stuff, the easier it gets over time from an anxiety standpoint, and you know, and you're kind of breaking this connection between a trigger and the emotional response. Now, the inhibitory learning model says things a little bit differently, but they're very much complementary, and I really believe that both are relevant. And I'll make a comment on that in a sec. But what the inhibitory learning model is saying that really the person isn't forgetting that this thing caused fear, but rather they're learning about how to inhibit the response based on new information that they pick up. So let's say here's a pen. I have I'll draw my face, so I'm just going to do that. I have a concern that I might on impulse stab myself in the eye. So my OCD is telling me that, so I put it down. Well, I learned based on that response that I'm not going to stab myself in the eye because I engaged in an avoidant or compulsive behavior. But what exposure is saying is that it's basically saying, hey, Eric, your OCD is predicting this is going to happen. It may or may not happen. I know you believe it. What percent do you believe it? 90%. Okay, let's do an exposure and then let's learn what happens based on doing that. And that learning is what persists. Now, I think that is a really important model to help understand why treatment works so well. I also think this notion of feeling better is really important because I don't want to tell someone, yeah, you'll be able to do all this stuff, but you're going to feel anxious, because that's also not what we see. People feel better as they get through it. And I think they feel better because they learn that these things are not actually going to happen. Now, the important thing I was going to say is I am not a believer of one person or one thing wins. So if anyone ever watched the new Roadhouse movie, which I highly, highly encourage,
What is it?
Roadhouse, the Jake Gyllenhaal, it was like the remake of the Patrick Swayze movie from maybe the 80s or 90s. Not that I personally was old enough to watch it then.
You just heard from your great great
Yeah,
grandparents.
right. It was on Wikipedia or something. But there's this great scene where the bouncer in Roadhouse beats up everyone, but he's sort of a pacifist, even though he beats everyone up. But he makes this comment of like, hey, like, can't we all be winners? And I think that's sort of this idea here, is that we can have different mechanisms of treatment that are relevant. And for the clinicians, it helps us understand what we might do differently or more of or better to kind of target to help people get better.
Yeah. I don't know if you both saw the second part to the question, but this is a good one too. So they were saying, like, after, facing the exposure, we do need to avoid doing the compulsions. But can you talk a little bit about the responsive thought? Because I don't know if you feel this way. One of the things that I always do is talk to new clients about, hey, what didn't work in your previous treatment? And one of the things I hear all the time is that they got really good behavioral component of ERP. They didn't get a good cognitive component. So the therapist never really addressed what to do with their thoughts. So when I asked them, what were you doing with their thoughts? They were like, please don't stab my eye. Please don't stab my eye. I don't want to stab my eye. And I'm like, do you see how you're sending conflicting messages? You're doing the physical exposure, but then mentally you're freaking out and your brain doesn't know what to do. So I'll toss it to both of you, is like, what can clients do when they're facing a fear with what's going on in their head? Oh no, Liz, we can't hear you.
Okay, I'll throw out, and then hopefully this will give us time for Liz's thoughts. We try to keep them engaged, because remember, the whole exposure is all about learning what's going to happen through that. So we want to have them consider the possibility of whatever the feared outcome is, that it may in fact happen, and the exposure becomes that mechanism for learning how the world works. I think when people are escaping, whether it's avoidance or rituals, you're losing this data on just ordinary things, or ordinary operations or events or so on. And so that's how we want the exposure to really be. It's that re-engagement. And our role as therapists is, Chris, as you pointed out, like, give them ideas, content. Well, maybe this will happen. I'm going to see what's happened. I'm being brave, but I need to sit through it to understand. But those types of things can be really helpful at getting to that outcome and facilitating the process.
Can y'all hear me now? Awesome. Right. So I couldn't agree more. And I want to go back to habituation for a second too. I think that the concept of inhibitory learning and habituation has been a little bit, I don't want to say confusing, but maybe misleading lately. So I've noticed a large group of patients feeling like you either do inhibitory learning or habituation. And that if you do inhibitory learning, you don't really believe in habituation. And so I just want to really clear that up and make sure everybody understands that inhibitory learning is, yes, it's kind of a different approach to ERP, in the sense that when I did ERP 15 years ago, you would hold something contaminated and sit and wait, sometimes for hours, for your anxiety to drop and wait for habituation to occur. Where now we're still doing the same exposure, but maybe we're not sitting and waiting, maybe because I don't have 3 hours, or I've got other stuff to do, or there's other reasons that wouldn't make sense. And so we're kind of moving through it and seeing what we can learn during that process. And we're focusing much more on learning versus SUDS levels, right? So in the past, in residential settings, we would say things like, SUDS, by the way, are subjective units of distress scale. So this is often that measurement tool of anxiety level, maybe 0 to 10. 10 is a panic attack, 0 is super relaxed and calm. And so we would say things like, what is your anxiety level right now? People would do the exposure. 10 minutes, 20 minutes in, we'd say, what's your anxiety level? And we'd wait until someone tells us it's reduced by 50% to say, okay, now you can move on. And so it was very focused on, what is your anxiety? What's your anxiety level? We don't do that anymore at our clinic, right? We're focused much more on, okay, were you able to do it with response prevention? What did you learn? How do you feel? Because I honestly don't really care what your anxiety level is, because what I'm trying to teach you is that anxiety is not dangerous. Anxiety doesn't really matter, and we don't need the full emphasis to be on anxiety. That is much more of an inhibitory learning model. However, that doesn't mean we don't wholeheartedly believe in habituation. And I talk about this all the time, that I still fully expect and plan and hope that habituation is going to occur for you. And if it doesn't occur, so if you're doing these exposures and it's not getting easier, and as Dr. Storch said, you're still super anxious and triggered, we're doing something wrong, or you're doing something wrong. You're holding on somewhere. Maybe you're doing mental rituals. Maybe you're doing some type of avoidance, or you're suppressing. And so I think it's really important for us to understand that it's not one or the other. I hope it's both, and I hope that when you're doing treatment, even if the treatment approach is less focused on anxiety levels in traditional habituation should still be occurring. It's still a mechanism of change that we expect to happen during the treatment process.
Yeah, well said. And I think for me, it gave me hope, right? Is it's not just about trying to get less anxious, because I do think sometimes people will say, hey, my anxiety didn't go down as promised. But the next time we approach that same thing, they're like, hey, for some reason, it didn't bother me as much. I'm like, because learning occurred. You learned more from the exposure. that makes today a lot different. Real quick, Eric, can you throw out your best contact information, unless that's weird? Because somebody's asking for it. It's not for your promise.
Yeah, just my email. I wonder if I can join the chat. I don't know.
If you put it on the back end for Emilio could put it in the comments. Okay. Somebody was just asking for a consult. You weren't here yet, Liz, so don't take this personally, but Marnie Jacob, who I love, said hi to us, two of her favorite
Hi,
people in
Marnie.
our OCD community. I know she would say all three of us. So I wanted to ask this question, because I think there was a question at the online OCD conference about like, how has your approach to treatment changed over the years? And I think this might help. So Kelly Rubin asks at 12:10 your time, Emilio, what about those of us who did ERP very rigidly and perfectionistically due to undiagnosed autism and PANS, and then traumatize themselves over 20 years? So I guess to ask the question in a general sense, sometimes people can say ERP feels rigid. Sometimes people can get perfectionistic about it. I read a quote a little bit earlier, Liz, about like people embracing exposures as things that get them back into their life, into the community, and make it a lifestyle. So how can we ensure both clinicians as well as people doing the treatment don't have this like rigid sort of manualized way that people then don't get like the benefits from it?
Mm-hmm. Well, great question. And this is, I guess I have a few thoughts. One is the field of psychology, psychotherapy, psychiatry has always struck me as a little bit weird, in the sense of we like train people to be these generalists. And that's completely different from every other domain of medicine, where you're actually trained to be an expert in cardiology. And even in cardiology, it's, subspecialties in cardiology or whatever. And so the first part is like, not every therapist knows how to effectively treat OCD. And so the key is finding one that does. Then I think the key is finding a match. And sometimes you have two awesome people, but they don't really connect on that. And then collaboratively work together on treatment. Chris, you asked sort of what's changed. I had a shocker when I realized I've been doing this for almost 25 years, despite being 24 in my mind. And there were a few things that were always sort of obvious to me. And one is like engaged family, whether they're closely part of the treatment process or you're, kind of having them in a strategic place. But that's a big part. And it doesn't matter if you're a kid or 17 or 47. It's figure out the people who are close to you and have them support you in this recovery process. I think a second is have a little bit of fun. And it doesn't, and that's not even just a kid thing. That's like across the spectrum part. I mean, this isn't a type of therapy where you go in and, as someone I saw the other day said, we talked about TV shows and their last therapist, which would be interesting. And I talk about my friends, but not in therapy. We're here to learn a particular skill set for dealing with particular triggers that are disrupting your ability to do the things that are important to you. And so we're going to collaboratively work together to push back and get all the things that you want, that you're missing out on. And so that sort of collaborative process isn't rigid. There's a warmth to it. There's a supportive aspect to it, but there's also a, hey, we're going to have to kind of push back on some things that are really pushing you away from the stuff that's key to you. And so I think that kind of active piece, that fun piece, fun being we're going to be playful with our exposures, can be really helpful. And that's been another sort of shift over time as well. Yeah, I don't know, Liz, Chris,
Yeah.
love your thoughts.
No, I agree. I think that one thing that's important to note is that ERP that was done 20 years ago isn't necessarily bad ERP. Like yes, we change, we improve, we grow. Of course, we should do that every year as we learn like new ways to talk to patients, new metaphors, new analogies, like kind of you name it. But really, the like crux and foundation of ERP is actually the same as it was 20 years ago. We just hope there's been improvement in both the way we administer and deliver treatment and that sort of thing. I think that if there's undiagnosed autism and PANS and things that would make treatment look a little bit different, what's important now is to figure out, okay, how can I make this treatment better for me, knowing what I know now, right? Knowing my whole picture, my entire diagnosis, does it change the way I would engage in ERP every day? But the foundation itself around ERP for OCD actually hasn't changed. And I think that's important to note.
Awesome.
Yeah, I would say the biggest thing that for me personally is like when I first learned it, it did feel very manualized. But one of the things that I started to adapt to for the more and more trainings is that everybody that comes into your office does have OCD. And I know ERP is going to be one of the most effective treatments for them. And they're a person, right? They might have co-occurring conditions. They might be in a different place on their readiness kind of scale. Somebody may be experiencing, a PANS infection. Somebody might have autism. So there's different things that go on. We did a talk in the past about making sure to treat like the whole person. So that's another part is like a lot of my clients, when I asked them prior, like what didn't work, it sounded like they got amazing ERP, but then it was like the treatment was done, their Y box was low, and then they just went on and kind of relapsed because they had nothing going on. So I was like, okay, this time we're going to get you a job, get you back in school, have some structure so that you have things to live for. So the OCD doesn't seem as, as tantalizing if it tries to come back. So I think treating the whole person and being flexible. So Kelly, I'm sorry that, you kind of had that experience. So I definitely would say that's part of the reason why finding an OCD expert is so important is because we've all worked with clients for years. We've seen a lot of clients in different areas. Liz at running a residential has seen some of the most severe cases in the world. And it's like when you work with people that kind of get it, they're able to adapt, with your experience.
Mm-hmm.
There's a quick question for you, Eric. It's from Tom W at 1210. How is the low intensity focused ultrasound trial at Baylor going? Are there any results yet? I'm hoping that's something you know about, and I'm not going to look stupid.
Yeah. So one of the things that's amazing at Baylor are the faculty that we have here. So which I have to say because it's also my boss who's leading that study. But Wayne Goodman is looking at low intensity focused ultrasound as a possible way of non-invasively stimulating parts of the brain implicated in OCD. So one of the challenges with, let's take TMS and DBS. So DBS, of course, involves neurosurgery, which has, say no more. There's a lot of issues. Although on the other hand, it's really, really effective when people haven't gotten better from ERP, from medications and other forms of treatment. But again, certainly challenges there. TMS, one of the challenges there is, while it's non-invasive, it's the penetration aspect. So if you think about how stimulation works, there's kind of a coil placed on your head, and whenever you stimulate, it's not like if this was the stimulation level, I can't do that. It doesn't go like that. It comes in a cone, so it's a little bit trickier to actually target, and the effects that you see are okay. Like, one of the big studies that was by Carney in, I think 2019, showed a 7-point versus 3-point difference on the Y box. So 7 points for active treatment, and then 3 points for sham. So it wasn't a huge effect when you saw 30 sessions over 6 weeks. Like, that was, I think if we had someone go to, Liz's program, 30 sessions, I think we'd see a lot more than that separation on a Y box. So the idea here is that you can penetrate a little more precisely and deeply in this space. But what's cool about this study, and then, sort of the we need more work after it, is that it's really kind of showing that the target engagement, like that if you're using this, you can press the lever that we think is relevant here. And then that's going to be the pilot data necessary to go in for a bigger NIH grant where we can really conclusively look at efficacy, but also this idea of target engagement, which is what National Institute of Health is saying is important. It's not just that a treatment works, it's why it works. And then if you know why it works, just what we are all saying with inhibitory learning and habituation and other potential mechanisms, it allows you to really target those even more effectively and hopefully make them work a bit better.
This stuff excites me. So keep us in tune. I want to toss this question out because this is one of the things people will ask is, how do you notice if it's OCD or real life? So Jane Taylor asked at 12:30, the news is triggering. I'm trying to microdose for my mental health. So the reason I wanted to ask this question is because I think one of the things I get from clients is they're like, well, the news is triggering or the holidays is triggering. Maybe it's not OCD, but then when we discuss it, it may not originate as OCD. I mean, there's definitely stressors at holidays or stressors in the news, but their approach to handling it both mentally and physically, that's where the OCD comes out. So maybe talk a little bit about that when OCD latches onto something real, and how do people handle if the news is triggering and things like that to not sink from, you know, stuff we can't run away from.
Mm-hmm. The news is triggering. Yeah, and I think, you know, there's sort of a difference between adaptive coping and avoidance, or maladaptive avoidance. You know, like, and one of the biggest things that I think about how to distinguish those is not just impairment, of course, but it's when it's challenging your flexibility here. So I want to watch the news, but when I watch the news, I get really upset on it, or it grabs on. And so your approach to that may be a little bit different than, you know, every time I turn on the news and there's, you know, something going on that distresses me, you know, I'm particularly worried about, will NIH have a budget cut? Because that affects the work that I do, and the work that benefits our community. And so I, to myself, just said, I'm not going to Google, you know, NIH budget, you know, 2026 anymore, because it's just not adaptive. So I think, Jane, what you're doing about kind of, you know, titrating down your exposure can be a really healthy thing to that. At the same time, if it goes against those values, you know, then you may, you know, think about either independently or working with someone on how you sort of push back against some of these things that you want to do, but it's difficult for you to do.
Yeah, what I always like to add too is what is the motive behind it. So if somebody is compulsively, I love that your water bottle looks like alcohol, by the way. I just want to say that.
Nah,
I'm like, is the morning already that tougher?
It's been
all
that
of us
type of
drink. Yeah.
By
So
the
what
way-
I'll say too, though, if it's okay to hop in, is that I want us to kind of slow down for a second and be thoughtful about the concept of not fragilizing individuals with OCD. You know, so yes, the news might be triggering, but if the news is triggering, we can't just say, okay, well, I'm just going to avoid the news, or I'm going to, you know, do things to avoid being triggered because it's too hard for me, right? And I hear this question about work, like, should people accommodate so that I don't trigger this person I work with? And the answer is like, actually, no, that individual should get really good OCD treatment, because if you get good OCD treatment, the news no longer has to be triggering. So yes, it's okay right now to say the news is too triggering, I can't watch it, but don't make that a choice you're making to accommodate to your OCD. Instead, say, hey, the news is triggering. Wow, that is an indicator for me of things I need to be working on, of things that are still activating me that I haven't done, you know, my appropriate ERP and work on yet, and focus on that in therapy. So I just want to make sure I throw that out there, because I do think sometimes we start to fragilize ourselves, or other people fragilize us, in the sense that we send ourselves this message that I can't tolerate that. I can't be triggered. I can't handle the news. When the reality is that with effective treatment, you absolutely can. And the news can become the news. Again, as Dr. Storch pointed out, doesn't mean there's never going to be something on the news that makes us feel sad, or that makes us feel upset, or that makes us anxious. But there's a difference in something being like not jolly on the news versus it triggers my OCD.
Yeah, what I want to add to that, and I'm glad you pointed that out, is one of the things I think that happens to people that have OCD, especially if it's been misdiagnosed, underdiagnosed, or not diagnosed at all, is like you were saying, Liz, like people start to create beliefs about themselves. And I think one of the beliefs that people create that have OCD and anxiety is like, I can't handle tough things. I can't handle hard things. I have to figure out every day how to kind of live in this culture of avoidance to prevent myself from having a stressful moment, because I am somebody that's weak and cannot handle toughness, right? And so sometimes when I'm first working with a client, and if that's their mindset, before jumping into ERP per se, I really am just starting to say, let's look at some of your strengths. What are things in your past that you've overcome? And what's always crazy is people will have these backstories of these like horrific things that they've overcome. They might have lost a parent early, or been in a horrific car accident, or fought cancer. And I'm like, okay, I'm looking at somebody that's impressive. I'm looking at somebody that's, you know, climbed Mount Everest, or, you know, done something really, really tough. It isn't that your personality and you as a person has changed. It's just, unfortunately, you've been giving into a disorder for so long, and you've kind of created this sort of learned helplessness where everything is scary. And I do agree with you, Liz, that, you know, our job as clinicians is to help bring those clients back to believing that they can handle toughness and they could balance. Because yes, at the end of the day, we want people to know their motive. Why am I checking the news? Am I avoiding the news because it's just too much and the news is sensationalized? Or do I not think I can handle it? And like Eric was saying, you could do it in a systematic and a collaborative approach. But I don't know how you both feel, but like, especially if I work with a client with pretty horrific, taboo, intrusive thoughts, they start to think of themselves as like disgusting or like a stain on this earth, or I don't even deserve Christmas gifts because I have these thoughts about children. And it's like the disorder is almost allowing you to, I think of the disorder as like in a I know nobody likes the P word, politics, but it's like almost like if you're running a campaign, your opponent is, you know, is trying to make you look like this horrific person. Even if you've like saved lives and fought in the military and done these amazing things, your opponent's going to make you seem like you're the worst person ever, right? That's how I picture OCD. Is OCD is kind of trying to con you into thinking that you're this absolute like disgusting human being. And part of the point in treatment that I don't think ERP gets credit for, and the OCD treatment in general, is we're also trying to reconnect you with your identity and who you are, so it becomes harder for OCD to trick you. So if you're walking down the street and OCD is like, you're going to push people in the middle of the street, it's like, but that isn't Chris. People ask me all the time, like, Chris, do you still deal with OCD? And I'll say all the things that were never aligned with me, the sexual intrusive thoughts, the harm thoughts, all that stuff doesn't even come up because I wouldn't even invite it in, because I just know that's not me. So I think that's an important part that we don't always give the credit to treatment as well.
Yeah, I always talk about it. Good treatment should give you clarity. You're not going to get it during the treatment, right? But afterwards, you should be able to be really clear that, like, oh yeah, that was my OCD, like, and kind of be able to even joke about it or think it was funny that at one point that triggered you or scared you.
Absolutely. That's always the fun part, when you can like laugh at old things or like, oh, I used to not be able to do that. That's awesome. I want to say real quick, there was about 5 questions that I saved on Wednesday, January 15th. We're going to have a psychiatrist on. So there was some psychiatry and TMS questions. So I saved those for that. So if you ask that question, it's not that I'm ignoring it. We'll have a psychiatrist actually from USC who also does TMS and stuff, so we could talk about that. I don't know if this is for you or Liz, Eric, but Amy Ellickson, who's a good friend of our show, asked, what are the latest results to come from OCD Enigma? Is that something either of you are part of, or?
I am not part of that. And I was looking at that just to Google where the latest results. There is a website. If you Google Enigma OCD study, it is the first major hit, and they should give some data. They've had a really rich sample collection, in terms of genetic analysis. They've done a lot of harmonized imaging and assessment. It's a really, really elegant study, across the world, including, folks from Africa, Brazil, Europe, US, Canada. So anyway, but Amy, I would check out that website, and I believe there should be some updates on there as well too. Yep.
Yes. So, Chris, I would love to throw it to you for a second, because you've been throwing us all these questions, but I want to just ask for you, like, what for you was one of the big turning points? Like, when do you feel like things clicked for you? I feel like a lot of patients ask this question of, did you have an aha moment? But what was it like as you started to do ERP? When became that moment that you realized, like, it really clicked? Like, how to truly change your relationship with anxiety and OCD versus just doing ERP for specific symptoms?
Yeah, I mean, one of the reasons, thank you for that question. One of the reasons I include this picture in if I ever do a talk about my own personal story, it was this picture. My mom made a comment once when I was like going through my OCD treatment. We're looking through these photos, and she was like, this is the last photo I have of you where you were really fearless. You would go up to strangers and talk to them. You would be the first one to raise your hand. You were never afraid to talk in front of a crowd. And when OCD hit, you became a different person. You became scared, hesitant, shut down, and everything. And I know my mom didn't mean to say something profound. In fact, I actually was hurt by it at first, but it actually like was really important, because I remember going home, because we used to carpool to my treatment, and I went home and I was kind of thinking about it, and I was just like, you know what? I'm a shell of myself. I don't even know who I am. And the reason I am such a fighter for ERP is because at the same time, thank God, part of my treatment, I was housebound. I mean, I was really only leaving my house to go straight to my therapist and back. And one of the exposures was to start to go to a grocery store during the daytime, because I obviously needed stuff from the store, but I would go to this 24-hour Ralph and go in the middle of the night when no one's there. And I remember my first time, it just so happened to coincide with what my mom said. And I went to the grocery store, and where I lived was by the beach, and I was seeing people my age. I learned how to surf when I was in Hawaii when I was like 12. And I just saw a bunch of surfers my age laughing it up, like buying hot Cheetos or something crappy for your system, but they're just like eating and like laughing. And I was like, I'm about to leave here and go home and do 10 hours of compulsions. Like, this isn't my life. Like, how did I get here? I think what happens with OCD is everything happens so rapidly. I always tell clients, it's like that kind of like heating up a crab in hot water. It's like OCD is smart enough to do it slowly and systematically until next thing you know, you're housebound. And I just remember going home and crying to my mom, but laughing at the same time. I'm like, there's these kids living their life, and here I am keeping Tide in business because I can only use, laundry detergent once. I have to throw the whole bottle away. And so I think turning the camera from me to out and starting to see the world and seeing people live and thrive my age. I hadn't really interacted with somebody my age in like 6 years at that point because of being housebound, and seeing my peers, even though they don't even know who I am, thriving. I was like, why can I get that? And I remember going to my therapist kind of renewed and just saying, I want to be a normal 22-year-old. I want to surf. I want to like eat bad food. I want to like live. I am so sick and tired of having my dad cook my food, cut it up, feed me. Like, how did I get here at 22? So I think for me, it was like almost that moment of getting out of my house during the day and seeing other people. It was like, how did I become such a shell of myself? So that was for me. How about same for you?
Yeah, I always tell people, like, I think people want this aha moment, or they want this magical kind of thing that someone said. People like want me to say something that's going to like make it happen. And what I always say is that the aha moment and the magic actually happens after, right? So when you think about ERP, it's behavioral first. Like, you're not going to feel up for doing exposures. You're not going to feel not anxious until you do the exposure, right? So you do it first, then you feel different. And to me, that's how treatment was. Like, once I did ERP and started to see results and started to see that I could live that life I didn't realize I could live, or that OCD didn't have to make decisions for me, that's when things changed.
Mm-hmm.
I think that
So,
permission too in treatment early on of like, you can talk back to this thing. I remember my very first exposure, my taboo stuff was a lot harder. So we didn't start with that. We started with my contamination. But one of my first exposures is I used to run everything. I had to share a shower with my dad. And I had to, because I didn't know what he did when he was showering, I always had to run all my bathroom items under hot water to clear off the germs he may bring to it. And I remember that was like my first exposure, because it was pretty simple to just not run my bottles of water under hot water. I started with cold water. And I remember, even though it sounds so small, to like actually do it and to fight back, it was like, holy crap, this thing in my head actually like shut up when I did the thing it said not to do. I think now, upon reflection, one of the things that I always talk to families about is your loved one wants to succeed. They want to overcome things. They want to be challenged. I mean, kids want to learn how to walk. Kids want to learn how to like ace a test. People want to throw a fast pitch. Like, people want to achieve things. And OCD doesn't allow you to achieve anything. You're just avoiding the world. And so as people start to face their fears and they start to accomplish things, and success breeds success, I feel like your brain kind of lights up and is like, we're back, baby. Like, we're beating things, we're doing things, let's go. And so I think that, that's how I conceptualize the treatment, is like, let's get your brain back to being successful, to overcoming things, and let's be proud of that.
Mm-hmm. Well, that tells you the mechanisms. I mean, both of those examples. So, and I suspect, that this is the same for many people. So it's all about, okay, getting it back. What are you missing out on? What do you want to do? How do we make that front and center? And keeping that light right there. It's a perfect example of how, when you understand the why someone's being driven, that you're able to target that, and that's how you get better outcomes.
Yeah. I wanted to ask this question by Beth at 1234. One of Beth's fears, she's a good friend of our show, hi Beth, is getting long COVID. But part of the additional problem, as she says here, is like she also has a fear of going to the doctors, going to a hospital. I know obviously we can't give her individualized treatment in the moment, but what I'm more interested to hear from you is how, as somebody with OCD, can somebody start with the idea of like, what is the mindset somebody needs to go into? Because I think OCD does this a lot. It's like, well, if this happens, then I'll have to do this, but I can't do this. So this can happen, and you're kind of stuck, right? OCD gives you these puzzles that don't have an answer. So how can somebody with OCD start to say, okay, I have this fear of getting long COVID, can't go to a doctor, can't go to a hospital, I'm stuck, I can't do anything. What's a good place to start for someone to start moving forward in recovery?
Yeah, I think there are a couple of things I really like to say, in terms of this. So what are the things you can't do because of OCD, but you want to do or need to do? The other part is really highlighting that it's not a black or white thing. So, in Beth's comment, which is, a common fear, it isn't if I don't go to the hospital, everything's good to go. There's a significant loss that goes with that. So I really like to encourage people or ask people to say, okay, well, if you continue on this pathway, what's the flip side to it? So the flip side to this is that, if I'm not going out or going to the doctor or so on, then there's going to be some other detrimental outcome that takes place, whether it's health related, social related, all the above, or other stuff. And so now all of a sudden it starts really kind of, creating a contrast. You see this all the time, when people are describing these unwanted intrusive thoughts of harm or, sexual stuff or what have you. And the irony is there, like I get how powerful this is and how painful this is. But the concern that if you on impulse acted on this thing that you're not going to act on, if you hold on to that, well, you're ensuring actually that the feared outcome happens. So it may be that you don't kill someone on a hit and run, but your withdrawal from the world ensures that your life is ruined, that you're not able to get out there, as opposed to this other alternative, which is that this is OCD. And it's sort of like your brain playing a trick on you. And the only way you're going to be able to discern that is by pushing back on that in a gradual, systematic way to start learning, hey, is this real or is this just my OCD playing tricks on me? And so that's a big one for me, because it's not, OCD isn't occurring in a vacuum. So not going to the hospital, not going to doctors, not going out in public because of these, fears that are really driving that. It also has these consequences. And I want to make sure that those consequences are really elevated, so that we can get some of that motivation to get back on these things.
Liz, I have a question for you. Thanks, Eric. This is actually what we talked about with Michelle Massey at the conference this summer. Amy is a mom and says, I catch myself fixing things in the fridge because I thought it would trigger my son. So an example is I move meat away from foods he likes because raw meat, even in secure packaging, bothers him. So family members can also think of their loved one as fragile and act accordingly. Can you just address that? I feel like you were powerful at our talk this summer about it.
Yeah, no, this is like the bulk of our family therapy work here at OCDI, right? All of our patients in our resin PHP program have a family therapist and are doing family therapy every week. And the bulk of the work is teaching family members how to not fragilize your children, right? How to be okay living the way you would live, whether someone had OCD or not, and knowing that it might trigger them. They might be anxious, but that's okay, right? Again, what message do we want to send to our family members? Do we want to tell them that they can't tolerate anxiety, that they can't manage anxiety, that anxiety is dangerous? Or do we want to send that message that, hey, you can do hard things? I talk about this all the time, but with my daughter, Olivia, who definitely has a little bit more anxiety than my other daughter, like every day we're talking about, right? She was afraid of the electric toothbrush one day. And it's like, yeah, like I hear that you're scared of it, right? We can validate, like, yeah, I understand this seems scary, and add a confidence boost, right? So, and I know you can do hard things, right? So the supportive statements are actually like you validate how they feel and you add confidence, which in turn makes them be willing to do it. But we don't want to say things like, this isn't scary. Why are you scared of it, right? Because it is scary to them. That's real. That's how they feel. Yet we don't want to also send the message that if you're scared, you can't do things, because that's not life. Guess, when my boss tells me to do something I don't want to do, or when I've got a project or a deadline, like I still have to do it and I have to work through it, even if I don't really feel up for it.
Mm-hmm.
Yeah, there was something that John Hirschfield said this weekend at the family group that I really loved. And what he said is, there, and I think you were talking about it in one of the early episodes of your podcast, Liz, with uh, oh my God, with Callie. Her name is the same state I live in. I should know that. But no, you were talking about it as well. It's like there has to be this conversation from loved ones. There can't be ever anxiety in your life. Anxiety is part of our life, and if you want to take it even more meta, when you come from it from a mindfulness perspective, there is no real good or bad emotions, right? Like anxiety is a good motion because it kicks your butt into action when needed. We just unfortunately get signals that are unnecessary. So people are afraid of raw meat because it can get people sick, yet in a secure packaging near an item is not the same, right? So if you as a parent treat it as scary too, your loved one is learning two things. One, hey, maybe there's some basis to this fear. And then two, I can't handle scary things. But your son's boss, your son's roommate at college, your son's neighbor, like your son, the person driving behind your son that thinks he cut them off, isn't going to have that same like kind of hand holding experience. So we got to kind of teach like anxiety is okay and we can land on our feet and handle it. Marnie said she loves you too, Liz, and she wrote an amazing post about or comment about people being strong. Real quick, I know we're almost at time, but somebody asked this question that you're Dr. Storch, that you're two people asked about your research article involving MECP2. I think it's a gene that might have to do with OCD and autism. Is there more information that's coming out, or can they find something about it?
Yeah. So nothing specific about the MECP2. Yeah, and this is one of the beautiful things about team science is in no way am I a geneticist. So God willing, in 2025, you'll have some geneticists on and to see that they can answer that better than I. There are hopefully soon some really exciting genetic findings that are still under review in OCD. So there'll be the largest genome-wide association study ever in OCD with over 50,000 people with OCD involved. And so that's there's more discoveries that are coming through that. And then there's really a lot of attention in other areas of OCD. So we're doing a project in Latin America that will have 5,000 folks with OCD who are of Latino ancestry who will contribute to that effort, but are not in this current analysis. So again, lots of movement in the scientific field, whether it's genetics or imaging, lots of movement in terms of therapy. One of our studies we're really excited about is where we look at can we replicate Blair Simpson and Edna Foa's work and medication discontinuation after achieving remission with ERP. In this case, in our study, in children with OCD, which was generously funded by the foundation. So again, we're hoping to not just be able to say, hey, here's the treatments that work, but after you've gotten better, here's how you discontinue some of those things. And we have great answers, of course, with CBT. We have some data now in adults with OCD, but really critical to get this in kids. So those are a few things that will come out in the next couple years.
Awesome. All right, time for final thoughts. I'll go first. As being the last stream of 2024, what I just want to say to everybody is as the end of the year hits, in a curious, non-judgmental way, I want you to just take a second to reflect on 2024. Do you feel like you've done as much as you can to recover from this disorder? I always have a comment that I make to my clients, like when the head hits the pillow at night, do you feel like you've done something to get your life back? So the reason I say in a non-judgmental way is because this isn't about shaming yourself, but it's really asking yourself, do I feel like I'm doing what I need to so I can get back to the things that I love? I want you to think about that. Thank you for joining us in all the streams in 2024. Have a great holidays because we'll fall on Christmas and New Year's Eve or New Year's Day, so we won't be here. But on Wednesday, January 8th, I'm back with Liz for the kickoff and first stream of the year. But I just want to say thanks for everybody that hung out with us today, ask questions. I'll let you two fight it out for the next final thought.
Yeah, I'm happy to go next and let Eric get final words. What I'll say is the same thing is, the question I always ask is, if OCD is lingering, what are you holding on to? And can you approach anxiety and OCD with this bring it on attitude, right? As long as we continue to approach it with this, like, please don't come at me. I don't want to feel you. I don't want to be triggered. I don't want to see you. It's going to win. But instead, if you look at it as this, like, bring it on. I'm not afraid of you. I'm not afraid of what you throw at me, and I know how to handle it. You will truly be able to see the entire relationship you have with anxiety and OCD shift and change. And when you start to see that, you can generalize it, and it's amazing. So I hope, and my goal is that for 2025, all of you are setting really clear, good, specific goals that are going to get you to that place of freedom from your OCD versus just functioning with OCD.
Mm-hmm. And to sort of add to that, and Liz, I think this what we talked about this before you stepped on, is this a Scandinavian study that showed 90% of kids were doing awesome 3 years later. And so it's just one of hope. So just as Liz was saying, if you engage with this in a more adaptive way, know that there is that light there, and that you will make it through. And again, the data show that. So keep that hope alive.
100%.
And you missed
Thanks,
it,
y'all.
Liz. The study was from Norway, and I got to be obnoxious on my Norwegian
No,
side.
I heard you plug that. I was just in the background, but don't worry, Chris. I heard that. Yeah, you're plugged. So love him. He didn't talk about being Greek, so that'll happen in 2025.
Absolutely. Well, thanks everybody for joining us. We love this community.
Happy holidays.
We love everybody supporting, and go to IOCDF.org for everything OCD. Have a great rest of your holidays. Take care. We'll see you next year.